All right, so next topic we're now going to get into, after organizing our knowledge about immunology. Remember, we created two very large categories, two patterns in all of immunology: humoral and cell-mediated. And humoral was all about B cells and neutrophils patrolling the blood, and cell-mediated was all about T cells and macrophages patrolling the tissues. For humoral, it's primarily bacterial problems, and then for cell-mediated, it's everything else. So the key is organizing yourself so that anytime they give you a patient who has a lot of infections or recurrent infections, you know they're going for immunodeficiency. And then you got to decide, is it humoral, cell-mediated, or both? And then look down at your list of answers, and you'll see usually only one answer can answer the question. So immunodeficiencies, I call it lacking a little bit. So the humoral immune system, again, protects the blood. What are the cells involved? It's the B cells, followed by the neutrophils. And we're talking about bacterial infections primarily. What about cell-mediated immune system? We're talking about protecting the tissues. What cells are we talking about? We're talking about T cells. We're talking about macrophages. But macrophages have a lot of different names, and we're talking about primarily non-bacterial infections. All right, so the non-bacterial infections starts out with virus. So if you take 100 infections, probably 90 to 92% of them are viral. That's the number one infection type, is viral infections. Followed by fungus, mycobacterium, protozoa, parasite. Then you can add collagen vascular disease, and then neoplasm. You go in exactly that order. If you go in that order, you'll rarely miss any question. And then what we're going to do is now go through in large categories. The first group are T-cell immunodeficiencies. Well, if these are T-cell immunodeficiencies, then that's how to remember T cells are under cell-mediated. So cell-mediated is all about tissue infections. And in tissue infections are going to be viruses and so forth. If they ask you what's the most common virus, remember CMV is found in 95% of people, followed by EBV found in 70% of people. So from the beginning, the T-cell immunodeficiencies, first one is called DeGeorge syndrome. In DeGeorge syndrome, the main thing is the third pharyngeal pouch is missing. The third pharyngeal pouch. Remember, in embryo, the arches give rise to muscles and bones, and pouches give rise to organs. So in this, DeGeorge syndrome, third pharyngeal pouch is missing. And this is why the thymus is involved. So that's why they have a T-cell problem. And then the inferior parathyroids is also involved. So because the inferior parathyroid glands are involved, they have a relative hypoparathyroidism, which then makes their serum calcium low and their serum phosphorus high. So this is the only immunodeficiency with a real electrolyte problem. In fact, this is the only immunodeficiency with a calcium problem. So with low calcium, remember, you are more likely to depolarize, so that means they may present it to you as immunodeficiency with T cells, and then they have seizures or cramps or other depolarizations like arrhythmias. So DeGeorge syndrome, final clue, they're found on chromosome 22. Now you have 4 syndromes that run on chromosome 22, so that's a very high yield clue to know. So on chromosome 22, you got DeGeorge. So DeGeorge syndrome is the first one. But then also involving chromosome 1722 is neurofibromatosis. Then we have another disease called Ewing's osteosarcoma, which involves chromosome 11 and 22. And then finally we have CML, which involves the Philadelphia chromosome, which is chromosome 9 and 22. So chromosome 22 has 4 bad genes running on it. So chromosome 22 is not your friend. So again, DeGeorge, Ewing's, neurofibromatosis, and CML are on chromosome 22. So DeGeorge syndrome, thymus problem, so T-cell defect, low calcium because inferior parathyroids never developed. Next disease, chronic mucocutaneous candidiasis. It's chronic. In fact, they have it throughout their entire life. And then they have candidiasis on mucosal surfaces like the GI, respiratory, and GU tract. And they have it on their skin. So chronic mucocutaneous candidiasis. This is a T cell defect at the most submolecular level. Why do I say that? In this disease, the T cells can fight every infection under all else. Virus, fungus, protozoa, microbacteria, doesn't matter. It can even fight all the fungi. However, it cannot seem to fight candidiasis. So they have candida on their skin and mucosal membranes, and they typically just get chronic fatigue syndrome. Question is, why are they chronically fatigued? Because remember, fungus requires sugar. So that means the fungus on their body eats up the sugar that's in their body, and so the hypoglycemia causes the chronic fatigue syndrome. So the disease again, chronic mucocutaneous candidiasis. Next one, steroids. And this is a very interesting and very important piece of information. Steroids are the most commonly used, very potent anti-inflammatory drugs on the market. They're the best ones. So we use them for thousands of diseases. So that's why it's very important for you as a physician, for you as a student, to understand the main actions of steroids. So what I've done here is divided up into anti-inflammatory actions and physiologic actions. So anti-inflammatory actions simply means, how does it stop inflammation from occurring? The mnemonic we use here at the PASS program is IKISS, I-K-I-S-S. So the first I, inhibit phospholipase A2. If you remember, if you block phospholipase A2, you're not able to produce arachidonic acid. That means you can't enter cyclooxygenase pathway, and you can't enter lipooxygenase pathway either. So that means all inflammatory mediators, prostaglandins and leukotrienes, cannot be made. What about the K? The K is for kill off T cells and eosinophils. Think about it. Without T cells, the macrophages don't have anybody to present their antigens to, or their allergens to, for allergies. And then eosinophils, also involved in allergies. So if you can kill them off, that means they're not going to be around. If you remember, eosinophils are involved in allergies, and they're also involved in using IgE to remove parasites out of circulation. So again, the K kills off T cells and eosinophils. With this action, this is why the patient is now immunocompromised. This is why we say if somebody's been on long-term steroids, they are now considered immunocompromised because their T cells are gone or crippled. All right, now the second I, inhibit macrophage migration. If the macrophages can't come into the area, they cannot process the allergen for you. They cannot process the antigen for you. So that means the immune response is suppressed. Remember, macrophages must process the antigen first before there's a body-wide response to it. The two S's. First S is stabilize the mast cell membrane. If the mast cells do not degranulate, then you don't release histamine. And that's why steroids are used in allergic reactions. Then you don't release slow reactive substance of anaphylaxis. And therefore you don't release eosinophil chemoattractive factor of anaphylaxis. So you stabilize the mast cell membrane so they cannot degranulate. Then the second S, you stabilize endothelium. If the endothelial cells cannot open, then the monocytes cannot slide into tissue. Remember, monocytes are precursors to your macrophages. So if they cannot enter tissue, then they cannot become a macrophage. They have to stay in the bloodstream and remain a monocyte. This explains to you why we use steroids like in the case of cerebral edema, or when somebody has metastasis to their central nervous system. You got swelling around nerves. We use steroids all the time to shrink those swellings. All right? So that's why before you do radiation to the metastasis, we give them steroids. Think about why we use it in croup. When you got swelling around the epiglottis, well, steroids will stabilize the endothelium so that more fluid cannot leak into the area. So IKISS, I-K-I-S-S, are the 5 anti-inflammatory actions of steroids. What about the physiologic actions? The physiologic actions of steroids are mainly catabolic. What does that mean? If you remember in endocrine, we talked about cortisol as a catabolic hormone which raises your blood sugar. If you remember then, epinephrine was first, glucagon came out within 20 minutes, cortisol peaks in 2 to 4 hours, and a growth hormone comes out after 24 hours. All four will raise your sugar. So all steroids are a form of cortisol. So that means the steroids are going to create more sugar for you. So what they do primarily is break down proteins, so proteolysis, and then turn amino acids into glucose, so gluconeogenesis. So proteolysis for gluconeogenesis is the main action of steroids as far as their physiologic action. The other physiologic action, if you remember, cortisol is permissive under stress. Remember, thyroid hormone, T3, is permissive under normal conditions, but cortisol is permissive under stress, meaning it upregulates all receptors everywhere in your body. So if you give somebody steroids, that's why, like in an asthmatic, suddenly more beta-2 receptors pop up. And in anybody else, suddenly everything functions much better. So steroids and their actions. And then as we go through the list of steroids, let me give you the clues so that you can better understand which steroid drug do they want. You can figure out the side effects by the actions that we just discussed. Take the physiologic action. If you're going to break down proteins, that's why their muscle mass will decrease. That's why they get osteoporosis, because bone is a protein. That's why their skin gets thin, so they get striae, petechia, and purpura and ecchymosis, because they're thin, their skin is a protein. This is why they get fasciitis, because fascia is a protein. This is why they get easy tendon rupture, because tendons are proteins. This is why their TBG, thyroid binding globulin, decreases. So you can figure out what might happen. If I ask you about immunoglobulins, well, immunoglobulins are proteins, so those will be broken down. Transferrin, another protein, that'll be broken down. So we go on and on, but this is how you start to figure it out. And if you're turning those amino acids into glucose, that explains why people on steroids get hyperglycemia, develop diabetes, develop truncal obesity, because now the fats are left behind, but the proteins are being broken down. All right, so now let's go through the steroids, drugs, and go through their clues. First one, prednisone is the main oral form. So if you're looking for an oral steroid, that's the main one. Hydrocortisone is the main topical and injectable form. If you go to any pharmacy, Walgreens or CVS, you got cortisone 5, cortisone 10. So over-the-counter cortisone for all kinds of itchy rashes, that's hydrocortisone. Methylprednisolone is the main IV form. So if you were treating temporal arteritis, or a female with Takayasu, or somebody who's got metastasis to their brain, if you wanted to use IV steroids right away, methylprednisolone is the one we use. Then there's triamcinolone, used as an inhaled form in many cases. Then there's beclomethasone or betamethasone. Betamethasone, beclomethasone, B for baby. These are the two steroids that were once used to stimulate the formation of surfactant in a fetus who was premature. Currently, we like IM dexamethasone. So currently on a test, you look for IM dexamethasone first for surfactant production. If you don't see it, then you default back to the earlier ones, beclomethasone, betamethasone. What about the next one? Flutocortisone. Flutocortisone, mometasone, and the main nasal steroids. So if you got nasal allergies like allergic rhinitis, then they work very well. Next one, fludrocortisone. Notice at the beginning it sounds like fluids. Flutocortisone has strong mineralocorticoid activity, meaning we use it to take the place of aldosterone when somebody has adrenal insufficiency. Again, fludrocortisone takes the place of aldosterone when somebody has adrenal insufficiency. So what's the most common cause of adrenal insufficiency in children? Remember, 21 hydroxylase deficiency, followed by 11 hydroxylase deficiency. What's the most common cause of adrenal insufficiency in adults? Remember, abrupt withdrawal of steroids. Anytime somebody's been on steroids for more than 7 to 10 days, you have to assume that your adrenal gland has been suppressed. Your adrenal gland makes approximately the equivalent of 5 milligrams of prednisone per day. So when somebody's on more than 5 milligrams of prednisone a day, you have to assume after 7 to 10 days, you must wean it down slowly to allow the adrenal glands time to recover and take back control of cortisol production. So Flutocortisone is the one that takes the place of aldosterone, and then we give them prednisone to take the place of cortisol. The next one, steroid on the list, danazol. Danazol is the steroid that's used to treat endometriosis. It is a very androgenic steroid. So what you're doing is throwing off the balance in the female, so now she has more androgens than estrogen. More androgens is why then danazol causes increased muscle mass, increased deepness in the voice, polycythemia, increased appetite, all right, forgetfulness. Just think about male habits. So danazol. Next one is Cypropterone. Cypropterone blocks DHT, dihydrotestosterone receptors. This one is used in the treatment of prostate cancer if you don't want to use the other drug called flutamide. Next one, megestrol. Megestrol is the steroid that's anabolic, and we use it in medicine. Remember that most anabolic steroids are illegal. Those are the ones that athletes are sneaking around injecting themselves with, because those steroids build proteins. So they build muscle, but they also cause a lot of side effects like hepatic adenomas, like liver cancer. So not a very good idea to get into those. But megestrol is the only anabolic steroid we use in medicine because it improves the appetite of a cancer patient. And then finally, dexamethasone. Dexamethasone is the one steroid that has the best CNS penetration. Two other steroids you want to know, the ones that work very well in children. One is budesonide, and the second one is cyclosanide. Those two drugs have the smallest particles. The smallest particles, that means they go all the way down to the smaller airways of a child. So budesonide and cyclosanide are used a lot in children because of their small particles. So now we've gone through at least the most commonly used steroid drugs on the market, and I've tried to give you a clue for each one so that you know exactly which one they want when they write a question.